Hello, my name's Ken Kinter. I'm an assistant professor at Rutgers University, and the purpose of this training is to talk about general signs and symptoms of mental illness to law enforcement working in the community. So we have a couple different objectives that we're going to talk about today. We're going to talk about the basics of mental illness and addictions, particularly the interaction between people that are mentally ill and have an addiction, and they're interfacing with community law enforcement. We're going to talk about the DSM-5, which is the diagnostic manual for mental illness. And we're going to talk about recommended approaches to working with people with mental illness and addictions as you'll work with them in the community as law enforcement. So a little background on me, the professor part you know about already. I've been teaching since 2001, and I've been at Rutgers since 2006. And most of my experience, however, comes from working as a psychiatric screener, which is that psychiatric emergency mobile response that comes from the emergency rooms. We're going to be talking about that. Did that for about 20 years in 4 different counties in New Jersey. And a lot of what I'm going to talk about, my examples are going to come from out of that work, because I've worked with a lot of police and seen a lot of great work done, and then also seen some work where we can do better. So regarding mental illness, it's amazingly common in this country. 1 out of 4. I mean, there are probably people in this room right now that have a psychiatric diagnosis. Some of the more common ones are anxiety disorders and depressive disorders. However, I don't think those are going to be the ones that you deal with mostly in the community. I'm going to talk more about things like schizophrenia and the addictions, things that I think you're much more likely to have contact with in the community. So the interaction with law enforcement, you see this in the news all the time. There are lots of situations where these situations can end up in a fatality, can end up in police shootings, end up with violence on the part of the person with the mental illness. Very often, this isn't even in response to a crime. It can just be a situation. Mental illness can cause people to act and think and feel in a very erratic or disruptive manner. And whatever the situation is, one of the main roles there is de-escalation. De-escalation, and then, okay, where does this situation need to go from here? So mental illness involves changes in thinking, changes in feeling, changes in behavior. They can contribute to disruption in social settings or work settings or family settings, and they can also be caused by those things, as we'll talk about in a bit. Many mental illnesses start at a very young age, so you might be talking to teenagers or young adults. And mental illness has different levels of severity, mild, moderate, or severe. It's important to note that a person isn't always at that same level of mental illness. A person may be severe at certain times, may be mild at others. So just hearing the person's name shouldn't necessarily give you a hint as to where that person is right now. You may have repeated dealings with the same person when they're at different levels of severity, and that may influence the next step for that. I would also like to say that the different diagnoses that I'm going to discuss with you are also not indicators of severity. You can have a mild case of schizophrenia or a very severe case of anxiety. So some of the myths about mental illness, this one's the classic. People with mental health problems are violent and unpredictable. It's probably the easiest horror movie plot in the world. Get a person with a mental illness, give them a weapon, and then turn them loose. And unfortunately, that's how many people learn about mental illness, is through what they see on TV and movies. Might be an interesting question for you. Did you learn about mental illness at first through TV and movies, or did you have some sort of experience with it up close? Because that has a big way of shaping how people feel about mental illness. Another myth is that personality weakness or character flaws cause mental illness, and that people can snap out of it if they try hard enough. Mental illnesses are very similar to physical illnesses. You wouldn't ask somebody to snap out of diabetes or snap out of a heart attack or snap out of a seizure, but people, particularly with depression and anxiety, are routinely told to snap out of it and get over it. Good luck with that. It doesn't work. In fact, in a way, it makes the situation worse. Another myth about mental illness is that there's no hope for people with mental health problems. Once you develop a mental illness, they will never recover. And what we see in the research is that most people actually do recover. We've gotten a little better at that in the time that I've been in the field, but we still have a long way to go. So some of the facts about mental illness: it does not mean what we used to call mental retardation, or now is called intellectual disability. It can happen to anyone, regardless of intelligence, background, whatever. It is difficult to diagnose and to treat. That's part of the reason for the severe stigma around mental illness. If you break a bone, you can look at an X-ray and see right where that bone's broken, but you're not going to get a chemical test back to say, oh, Mr. Jones, you have bipolar disorder. So the fact that it's not so clear-cut to diagnose is one of the things that leads people to think that it isn't as real. Most mental illnesses are treatable, but there isn't a cure, just like for many medical problems. There's treatment and there's management. People with mental illness are more likely to be the victims of violence than the perpetrators of violence. And I would also warn you against the term psychopath and sociopath. We're going to be talking about antisocial personality disorder later. These are terms that you hear on TV that sort of describe phenomenon, but they're not really clinical terms. They're also sort of punitive and not particularly helpful. So let's talk about the causes of mental illness. And there's no really one answer to this. To break all of these words down a bit, what I'm going to say is it's an interaction between your heredity and your environment. We all have a chance of developing everything based on our age, based on our sex, based on our family background. So we have all these percentage chances. Then the environment may provide triggers that may set something like that off. So it's the interplay between the two. Now, of those things that may intervene to trigger a mental illness or addiction in someone that's susceptible to it, the number one thing we look at is trauma, particularly childhood trauma. Another thing that we look at is alcohol and drug use, which is also related to previous trauma. The continuum kind of goes like this. Person may have a hereditary predisposition to something. They experience trauma. From the trauma, psychiatric symptoms develop, and then the addiction develops from that as an attempt to medicate the psychiatric symptoms. That's kind of how it goes. So it's a multi-layer thing, kind of complex to deal with, but we'll talk about trauma a lot more as we go. So this is the DSM-5. It's a big book. It's not too much fun to read. I don't know how helpful it is. It's probably nice to have one around in the office, but I don't know how often people will use it. I know those of us in the field use it as necessary. But that is the Diagnostic and Statistical Manual. This has all of the mental illnesses and all of what we know in it. So let's talk about the different categories of psychiatric disorders. So if you open up the DSM, this is what you're going to see as the different chapters. We are not going to go through all of these. We are going to focus more on the ones that are in red, because these are the ones that I think you're going to be seeing more of in the community, and that's more where this is sort of geared. So let's start off with psychotic disorders. So I know you've heard the word psychosis before. Let's get specific about what it means. Psychosis means that one of these following things are present. So delusions, false beliefs. So you may have come across someone who believes that they're Jesus Christ, that they're a famous person, or that they know famous people. That's an example of a grandiose delusion. They have delusions that they have some sort of magical power or special ability. There may also be persecutory delusions where they feel like people are after them. They have some sort of special knowledge and people are following them or are after them. They really do believe these delusions. They're not making it up. They really do believe it. So challenging them isn't such a great idea. Hallucinations. With people with mental illness, hallucinations usually takes the form of hearing voices. It's voices that the person really is hearing inside their head. Maybe telling them persecutory stuff. It may be telling them funny, inappropriate stuff. Could be anything. They may be hearing these voices louder and more clearly than they're hearing your voice, which we'll get back to later on. There are also visual hallucinations. There are also tactile hallucinations. There's a hallucination for each sense, but with mental illness, it's the voices. It's one you're going to be seeing the most. Other psychotic symptoms are negative symptoms, which is where a person just isn't responding to you. They may not look at you. They may not speak to you. When they say something, there may not be anything in it. There may be no motivation, no nothing. Negative symptoms are the things that are sort of taken away by psychosis. It's more of almost an absence. Also, cognitive symptoms. Someone who is psychotic may have trouble organizing their thoughts. Their memory may be impaired. Their decision-making may be impaired. They're not in control of what they're thinking. We'll get to that as well, because we don't want that to be misconstrued as this person refusing you or not paying attention to you. They just may not have the ability. The psychotic disorder that we hear about the most is schizophrenia. You may also hear about schizoaffective disorder, which is very similar. This affects 1% of not only the US population, but also the world population. This is the illness that has the delusions that we were just talking about, the false beliefs, the hallucinations, the voices, etc. Disorganized speech, trouble thinking, and lack of motivation. People tend to develop schizophrenia from 18 to 22, may have some symptoms leading in before that. And it takes a duration of a few months for this diagnosis to be made. Now, one of the challenges with schizophrenia is if someone is under the influence of a drug, they may look like this. They may look exactly like they have schizophrenia, but it's the influence of the drug. The drug will wear off. In schizophrenia, it doesn't wear off. So depression, I know you've heard of this one before. Pretty straightforward. The way I explain clinical depression is, think about if you lost someone very close to you, a loved one or a family member. Remember how you felt right after that time? Well, clinical depression is the death didn't happen, but they still feel that way. They feel sad, they feel depressed, they don't have interest in pleasurable activities, they're not sleeping well, they're not eating well, all of these habits have changed. They may be thinking about death or suicide. And with a bereavement or a loss, it's bad right at the beginning and it starts to get better. With depression, you can just have episodes that are at least 2 weeks long. And the fact that there isn't a clear-cut external cause to it makes it more frustrating. You imagine being sad and thinking about dying and not wanting to live anymore and not having any idea why. So bipolar disorder, which used to be called manic depression, and you still hear that from people sometimes, involves, in short, mood swings. If this is your normal mood right here, people with bipolar disorder may swing up, they may swing down, they may do both. It's going to affect their energy level, how much they sleep, and how they function. So one direction that these mood swings can go is mania, which is, if you imagine having all kinds of coffee and you're all jacked up, this is what mania is like. They don't sleep, maybe hyperverbal, way over involved in activities. One of my, we went out in the field to see someone who had mania, and they were mowing their lawn at 4 a.m. on a riding mower with a flashlight taped to the top of the mower. Their neighbors were thrilled, as you can imagine. And then people can also swing down into depressions as well, where they become very suicidal. So next up is anxiety disorder. Anxiety is a nice clinical term, roughly equivalent to just feeling fear, feeling afraid. Some people have anxiety that spikes in the term of like a panic disorder, where all of a sudden they're just in full panic mode. I'm sure you could probably relate. We've all probably been in panic mode at some point before. But again, this one can come out of nowhere, or it can be triggered by something in the terms of a phobia. If someone is, say, afraid of a door, or afraid of dog, or afraid of heights, or afraid of being outside. So with some of them, it's the anxiety spikes, and with some of them, it's just a heightened level of anxiety all the time, anxiety and fearfulness. Very prevalent. But again, I don't know how much of this you're going to see. So another type of disorder, and you've probably heard of this one as well, is obsessive compulsive disorder. And obsessive compulsive disorder is sort of a two-part thing. The first part is obsessive thoughts. There's just this thing in the person's head, and they can't get rid of it, and it's just going around and around and around and around. So what do? You have this thing going around in your head. So there's some behavior that will almost completely get rid of it. Almost completely get rid of it. So you're very anxious about people. You're obsessed with the idea of your house being broken into. So you check the locks on your house 20 times before you go to bed. And this behavior makes you feel just well enough that you can go to bed, but then you're going to be laying in bed thinking, did I lock the door? Is this the night they're coming in? So there's all different types of behaviors that fit into this. You may have seen hoarding before, where people keep all sorts of possessions. You may have people that have to do things a certain number of times. You may have people that have to check things like locks or the oven over and over again. There's a client I'm working with who is very afraid of being contaminated. So they take 3-hour showers, repeat, sometimes more than one in a day. So it's this pattern of obsessive thinking and then the compulsive behavior. Another disorder that we hear about quite a bit is post-traumatic stress disorder. We talked about trauma a little bit already. The reality is that many people have either witnessed or experienced a traumatic event: physical abuse, sexual abuse, neglect, a natural disaster, some sort of violence. And it doesn't even have to happen to you. Witnessing it can be enough. And it doesn't go away. The textbook example of people with PTSD would be, say, Vietnam veterans. They're back home. They've been home for 30 years. They still don't want to deal with the fireworks on the 4th of July, or they still get nervous every time they see a helicopter overhead. They've been trained to equate danger with those things, and that lesson just doesn't go away when that person comes home. So they relive this experience over and over again. They try to avoid these experiences wherever they can, and they feel like they're on all the time, may not be able to sleep, and may have trouble functioning with other people. So PTSD lasts at least a month, and it can last a lifetime. Nightmares, suspicion come along with this, and people with PTSD are also very prone to addictions. And a very sad statistic about PTSD is that we've lost more Vietnam veterans to suicide than we did during the war itself, and that's a very sad state of affairs. So moving on into addictions. There are a couple different types of addictions. One is obviously the substance abuse, and then there's also process or behavioral addictions. So substance abuse, textbook. People that are using any number of things. We have a list coming up. There's more coming out all the time. Substance use disorders can be mild, moderate, or severe. Mild, somebody just has a problem with it every now and again. Moderate, it's becoming a more significant problem and they may require treatment. Or I'm sure you've met people that have severe addictions, whether it's alcoholism or whatnot. A couple of the criteria that determine whether something's mild, moderate, or severe is tolerance. If you know someone who can, say, drink a phenomenal amount of alcohol and be unaffected by it, that's tolerance. And that takes practice. You don't just get tolerance. You have to work for it. Withdrawals. The most common example of that is when someone gets the shakes when they haven't been drinking. So those are the signs that we're moving into the moderate and severe end of the spectrum here. Substance intoxication and withdrawal, pretty self-explanatory. The trick of these is that they look like other things. For example, if someone's withdrawing from alcohol, they may see things, the proverbial pink elephants. So it may look, oh, this person has schizophrenia, they're seeing things. Well, we do a little more information, we find out that they just stopped drinking after being drinking for a long time. That might be causing what's going on. Substance-induced disorders. I don't know too many people who have an addiction to a substance that don't have also some sort of mental illness going on, either preceding it, as we were saying before, or sometimes the prolonged drug use can actually contribute to a mental illness. For example, people that use cocaine for a long period of time tend to become very paranoid. Remission is when someone has actually stopped using for a period of time, and there's a whole process that people go through. Just because someone stopped using doesn't mean they get better. In fact, in some cases, they can get worse because now the underlying mental illness is unmedicated. A lot of times, addiction is used as a method to medicate trauma or medicate psychiatric symptoms. You take the medication away, sometimes the person gets worse. So in addition to substance related addictions, there are also process addictions. Gambling is a very common one. That's everywhere now. There are other process addictions such as video gaming, sex addiction. You may have contact with people who are involved in these addictions as well. And here's our list of things people can be addicted to above that. And there's many more than that, I'm sure. So moving on, we're going to talk about personality disorders. Now, the interesting thing about personality disorders, they're different from any other type of disorder. They're a disorder of personality. So they really are part of the person, and they start at a very young age. Other differences are that, unlike these other disorders we've just been talking about, there really isn't medication directed at these disorders. They don't respond that well to medication because, again, you're medicating part of that person's personality. The other part is they may not feel bad about these symptoms. Like, nobody wants to feel depressed. People don't want to feel anxious. However, if this is your personality, this is just who you are. And it's very pervasive. It really affects the way that person sees the world, how they feel, how they act, and how they behave. And we'll talk about two of the more common personality disorders coming up. So the first one is borderline personality disorder. This is more commonly found in women, but not exclusively. And this is typified by a series of very intense, unstable, short-lasting relationships. And in a relationship, that person gets put up on a pedestal, and then they immediately get pulled down again. Then there's an explosive breakup, and then they go back and do it again. Basically, the person has, it could be said that they kind of have a hole in themselves. They feel empty, and they keep trying to put things in this hole. Money, sex, substances, relationships, all of them fail. And they go through this cycle of up and down and up and down. And when it's over, it tends to end in an explosive manner. There can be suicidal behavior, or one of the really telltale signs of borderline personality disorder is self-mutilation. You may see someone who has 50 or 100 cuts or burns, or even a name written in their skin with a blade. They're not trying to kill themselves. They're manifesting emotional pain through physical pain. Most people that I've seen that have borderline personality disorder have been the victims of severe and prolonged physical and sexual abuse. And this is how they express that. They feel empty inside. And then when these things fail to satisfy them, then the self-mutilating is a result. They don't feel the self-mutilation. They do it until they feel. Unfortunately, that gets worse as time goes on. So on the flip side of this, here's antisocial personality disorder. This is predominantly male, but not exclusively. And how you see this is, these are people that just have no regard for other people. They have no regard to the law, no regard to other people's rights. They will do things to people even if they don't have anything to gain out of it. They lie, they con, they manipulate. I worked with someone with antisocial personality disorder who had killed someone with a shovel. Didn't lose a minute's sleep over it. His feeling was that person shouldn't have been there. If they hadn't been there, nothing bad would have happened. So there wasn't even a reason that you could say why this person would have done it. Most people who have antisocial personality disorder are either incarcerated or dead by the age of 40. This is a hard way to live. But they will also have repeated contacts with law enforcement. Now, people with antisocial personality disorder, and this is back to that psychopath, sociopath stuff we were talking about before that I told you to avoid. People who have antisocial personality disorder tend to present in one of two ways. One is very intimidating. I'm going to get my way by intimidating you. You're either going to give me what I want or things are going to go really badly for you. The other one is that they present as very charming. Someone you would buy a used car from, someone you would trust your children to, someone you would vote for political office. And I'm going to stop there before I get in trouble. So we're moving on to medications now. And so there are different classes of medications, and I'm not going to expect you to know a whole lot about these different types of medications, although it's helpful that you can look them up in the field now through the internet, but that's a little dicey as well. My recommendation to you would be that when you're working with someone, that you ask them what they're supposed to be taking and what they are taking, and just write that information down and pass it along to wherever you're going. I think that's the most valuable addition you can have to that, just to be able to document that. So there are antipsychotics. These are the medications that are to reduce psychotic symptoms like the hallucinations, the voices, and the delusions, the false beliefs we were talking about before. There are antidepressants whose job it is to help people feel less depressed. There are mood stabilizers. Those are for bipolar disorder to keep those moods from swinging up and swinging down. Anxiolytics are anti-anxiety medications. These can tend to be very addictive. Xanax is probably one of the ones that you may have heard of. Klonopin is another very common one. They can be very addictive. They can be problematic, but they also treat anxiety. The other trick about knowing what medication does what is a lot of medications are used off-label. So you don't exactly know what they're being used for. Some mood stabilizers are also anti-seizure medications. Some antipsychotics are also used for insomnia. So just because someone's on a medication, you don't exactly know what's going on with them. So that's part of the trick of it. Also, people tend to stop medications. A lot of people, when they first get out of a hospital, they stop the medications. I noticed a lot of people stop medications after a year's time because they feel like they're better and they don't need it anymore. And it's understandable why. You don't want to take medication. I don't want to take medication. It's expensive. It's a nuisance. And all medications have some sort of side effects. And the side effects for psychiatric illness can be pretty significant. Everything from weight gain to tremors to sexual dysfunction. Some of them are highly addictive. So it's kind of understandable why people don't want to take them. But for some people, that's what keeps them out of legal trouble, and that's what keeps them out of the hospital. So let's move on into communication skills, some do's and some don'ts. What you can expect. We talked before about how people that are suffering from mental illness have disturbance in their thinking, disturbance in their mood, and disturbance in their behavior. They may not be able to answer questions well. They may not be able to cooperate fully. The object is not to take that personally. They may be treating you the same way that they're treating everybody else. They may not have much of a choice. Another thing to think about is that the presence of police can sometimes be triggering to people who have past trauma. If they've had negative experiences with police in the past, due to no fault of yours, they may have a negative feeling. Most of the time we went out in the community, having the police there actually helped. It sent the message out that, you were here for their safety and that everything was going to calm down, and, and we could figure out what the next move was supposed to be. But for many people, the presence of police doesn't send that favorable message out. They may respond negatively to it. And a traumatic response is very often typified by fight or flight. So that means a person may react violently to police, or they may immediately try to escape, for fear of being incarcerated or whatever that case may be. So it's important to know that going in, because it isn't necessarily the fault of the person on the scene, but you get some of the blowback from that anyway. One of the main things that mental illness does to people is it impairs what we call their executive function. So if you think about executive function, the brain is the CEO of the body. The brain calls the shots. How are we going to act? What are we going to do? What are we going to say? All those processes go through the brain. Well, when mental illness affects the brain, now the CEO came to work drunk, or the CEO came to work high today. And these decisions are not going to be so well. And there's no other part of the body that can jump in and take over. So all of these skills that you see here may be impaired. So again, the person may just be unable to comply with even the simplest requests that you make of them. So we have the officer on scene, and the officer has a couple different responsibilities there. One is to make sure that the scene is secure and safe. Two is to find out what's going on with the person, to interview the person, and then also to get as many clues from what's going on in the immediate context, whether it's other people or just the surrounding area. So how do you get information? How do you collaborate information? How do you take information that you may already know about that person and figure out what the next move is? Obviously, safety is job one. And then how can we help this person being the next step? So some of the things that help is the officer being able to communicate what they've observed and what they've heard about what's going on with that person, whether it's their symptoms. We don't care about diagnosis. We'll work that one out later. Just what's going on with that person right now. What are you seeing? What are you hearing? What are people reporting is going on with that person? And do you have any idea of where that's coming from? So another thing to think about is just how you look coming on scene. Again, people respond to police in many different ways. You may be a very big authoritative person coming on the scene. You're also armed, and you carry the authority of law enforcement along with you, which that person may have had either a good or a bad experience with. Knowing that going in, knowing what other people see when you show up is important, because that's what they respond to. But that can also be a strong point for you. If you're there if that person sees you as, hey, you're here to contribute to the safety of this situation, that can be a cause of comfort. But it's interesting to see which way that goes. Again, most of the time we've been in the community, most people respond positively. It's not always the case. And then there are other factors that are involved in as well. In the screening end, we try to be as diverse as possible and have people that are local, and we try to take a person's age and race and sex into consideration. But you can't always do that because you don't always have that sort of availability. So sending a white police officer into a more diverse area, maybe an area they don't know as well, that can set up some disadvantages. So those are all factors that we have to take into consideration, because people judge based on what they see. So just a word on violence, and this comes out of our work in the hospitals. There are 3 types of violence: instrumental, psychotic, and reactive. Instrumental violence is planned violence, violence with a goal. Psychotic violence is violence that comes right out of the psychotic symptoms. I feel like you're the devil. The devil sent you to come kill me, so I got to get the drop on you first. And then the third is reactive violence. A person gets bad news and they just can't cope with it in the moment, and they, and they react in that moment. Think about these workplace shootings where someone hears that they've lost their job, and then they go back and shoot up the office or go home and do something there. It's right in the moment. So what are the things that you can do to communicate more effectively with people with mental illness? Clarity is good. Trying to look at the whys of the behavior is good. Does this look like this is a drug situation? Does it look like this person is psychotic? What purpose does this serve? All behavior is adaptive in some way, just depending on how you look at it. Saying things like, what happened here, instead of what did you do? Using I statements where this is what I need, this is what I want to do. Of course, representing that safety is the key reason that we're all there. Using people's words back to them, referring things the way that they said them is helpful. It shows you listened. You see on here, be low key and low EE. Low EE means low expressed emotion. So if that person is up here, we don't want to shout them down and be louder than them. We kind of want to bring them back down. Let's bring them down to where we are. Let's get out of that place where we're in our kind of feeling brain, the fight or flight part of the brain, and get into the thinking and decision-making part of the brain. Let's get everybody to breathe and settle down a little bit, and let's get into the problem-solving part of this. Avoiding power struggles. There's no power struggle. If a person isn't responding to your authority, it may be that they can't. I would go that way before assuming it was deliberate. It may be due to the symptoms, maybe due to whatever kind of condition they're in right in that point in time. So same deal, remaining calm, speaking slowly and clearly. Personal space. My opinion is that people with mental illness are far more sensitive to being approached. If someone's right in front of them or right in their face or trying to get around behind them, they're very sensitive to that. We try to avoid that. You want to be as non-threatening in your physical presentation as possible. And that can be hard to do. You're an armed person coming in a police car. How can we mitigate that intimidating appearance so that we can communicate with that person instead of if it looks like it's escalating the situation? No fast moves. Trying not to touch the person. Again, you never know when that person's been the recipient of physical or sexual violence before. The touch could be the touch of a perp to them. To us, it could be a hand on the shoulder, just trying to console. We don't know how that message is being received. And again, we don't want to get into a challenging situation with the person. One of the main predictors of violence is someone acting authoritarian toward that other person. So they get the idea that it's personal. It's not just the law as it's applied to everybody, it's you and me. And as soon as it's personal, the odds of violence go up rather greatly. So again, more of these sort of hints. We want to keep the stimulation level down. We want to be consistent. We want to understand if that person can't cooperate. There may be a reason why they can't. Don't take it personally. They may not understand what you're doing. But how can you communicate in a calm, peaceful manner what's going on? Make it clear that you're there to help that person, from a safety perspective and also from what needs to happen next. Some of the aspects of nonverbal communication are body posture. Standing with the arms folded is considered a closed posture. If your hand's anywhere near your gun, that sends a message out. In the hospital, we talked about when you had a clipboard in front of you. We used to view it as we're just holding a clipboard, but they viewed it as it's a weapon. You're going to hit me with it. Your facial expression, your eye contact. What are these? These are all things that you use to de-escalate a situation. Gestures, because gestures are helpful. And some people, you can see me communicating with my hands. But also when you are doing gestures, you may actually be closing the distance to the person as well. And they may respond to that. if they're already on edge, they may be very sensitive to that. Distance is an issue as well. I always recommend a little bit greater distance. At the hospitals, it's always like either 2 arms distance or preferably 2 legs distance, because that person may be coming from the perspective they may feel like they're going to be attacked. So the distance helps calm them to a certain degree, as well as hopefully making it safer for us as well. So the information that I got from the presentation is right here. I also threw on, I'm not exactly sure who the audience is here, if they're from different counties. So I put up all the crisis hotlines for New Jersey. These are suicide hotlines, and they're also, if you're law enforcement and you need backup in terms of having a clinician come out to assess the situation, these are the numbers that you would call. And the last piece on here is we have a website that has about 30 different videos on it, including this one, but also on other similar topics: addiction, mental illness, ways to de-escalate. If you see this link in the bottom, the sites.rutgers.edu, SHPRI, there's a bunch of videos on there. You can get certificates of attendance for attending them. You can do post-tests. You can also look up my name, Ken Kinter, Kinter. If you look me up on YouTube, there's about 30 different videos there, including this one. My hope is that maybe you get a chance to look at this in the future. Just write this down someplace. So you get into a situation, you might have this information, or you can use it as a refresher as well. So I thank you for your time. It's been nice talking to you. I hope this helps. Thank you for the work that you do in the community, both in terms of the community as a whole and specifically for people with mental illness and addiction who really need the help and really benefit from people who know what they're doing, can assess them well, and help direct them to where they can get help. So again, thank you for the work that you do, and I hope to talk to you and see you again at some point.